Epi seminar is one of my favorite. This is the first seminar I gave on campus 15, 16 years ago when I was first starting to do seminars, other than my job talk to be hired in biostat. So it's always good to come back here on a Monday and see everybody and have the chance to chat. One of my favorite musicals is Dear Evan Hansen. I absolutely just think it's such a cute little musical. And one of the songs has this, all that it takes is a little reinvention. And honestly, in this venue with you guys here, I'm going to be honest with you, that's all that I've done for the last 30 years is reinvent myself as times have changed. Sure, when you put it on a CV or when you talk to the NIH or you talk to somebody who's hiring you, I always make it sound like it was very planned. And this is, my career has turned out exactly how I thought it would. But the reality is you just respond to what happens as society changes around us, as our families change, as funding changes, whatever happens, we all kind of change and evolve. But what stays at my own personal core, whatever I do, are these 5 things. I'm always interested in health. I mean, those of you that have worked closely with me, you'll know that I read popular books on health and I read science books on health. I read it all. I listen to podcasts. I do lots of things. I'm really interested in health, which when I was younger was really biology because that's all I knew about health was biology. I love to learn. It's if I could do anything, my husband was asking me what I'm going to do in retirement. And I was like, oh, maybe I'll get a JD. And he was like, oh my gosh, what are you talking about? We were just talking about that this weekend. I really, really love to write. I write every morning for about an hour before I do anything else. Sometimes it's for fun, sometimes it's fiction, sometimes it's a grant, but I write every day. I actually love math. And when I'm sitting, I'm often grinding away at math in my head because that math is what calms me. Math is what centers me. Usually it's some derivative of the number 13 because I'm a little bit quirky and that my birthday is September 13th. So I'll be doing some kind of math in my head to calm the chaos that's usually spinning. And then the last thing is human interaction. Again, I love talking to people. I love hearing where people are, what they're thinking for their research, where they're going, and thinking about how we can work together in whatever we're doing. Sadiq mentioned my career progression, and I want to kind of lay it out a little bit differently. So I got a bachelor's in chemical engineering from Michigan Tech back in 1999. And a long time ago, I found all my old IDs. And so I incorporated it into a talk because I think it's hilarious to look at. Probably more entertaining for me than it is for all of you, but it always does make me laugh whenever I look at it. After I got my bachelor's in chemical engineering, it was the .com era. Engineering jobs were everywhere. You didn't even have to interview and people would give you a job. So I took a job as a diaper engineer at the Kimberly-Clark Corporation in Neenah, Wisconsin, and worked as a diaper engineer for about 5 years. It was my first foray into clinical trials. We made trying to make the diaper into a medical device. We were actually trying to have it treat diaper rash. That was my first big project. But then we also wanted it to diagnose diseases, check for fevers, look for proteinuria in urine. Those projects didn't really come to pass, but it was fun to work on. I was promoted, also known as exiled, to a diaper manufacturing facility in Paris, Texas. And that is really an Eiffel Tower with a cowboy hat that they have sitting in Paris, Texas, where I worked for about a year on the line, supervising mechanics and operators, hourly folks that were making diapers at 30,000 diapers a minute. I mean, these lines just fly by, but that was the job that got me back to where I really meant to be, which was right here with you guys today. It was miserable. I had a miserable boss. I had, the first day of work, I got there, he was from Alabama. I had married a man from Alabama, and he said, so Suzanne, you come down here and you're all important from staff. And I know you've just married a boy from Alabama. Have you decided whether you want to be a wife or an engineer yet? And I was like, oh, it's 2003, right? I thought you couldn't say things like that to me. But it turns out when you're in small town Paris, Texas, they can say a lot of things and you still have to keep going. But it pushed me into graduate school, which is when I went to Emory. I always wanted to be an epidemiologist. I just didn't have the words for it. One of those books that I read that I loved when I was young was In the Band Played On. I would have wanted to be Don Francis. If somebody would have just told me what Don Francis did, I would have lined up all my horses to be an epidemiologist. But at 14, I really didn't understand those complicated words. I then went on to get a PhD in nutrition because, like I said, I've also been very interested in health. And here's the truth. Again, sitting in this room with you guys, epidemiology at Emory paid $13,000 for a stipend. Nutrition paid $22,000. Why did I get a PhD in nutrition? Because they paid $22,000. And no joke. It's very serious that when you think about sometimes the reasons we make life choices, that was a really big deal to me, that difference in salary. So I went with the PhD in nutrition. Came to UAB as a postdoc, and the first big project I was on for Regards was a dietary pattern analysis. The reason I'm here at UAB is because George needed somebody to work on the nutrition data for Regards. He didn't think it was very interesting. He thought that nutrition was kind of an afterthought, but they had collected it and he needed somebody to clean it up and do something with it. This was a really exciting paper. It was one of the first big risk factors that we identified in Regards that really helped to explain why there are these racial differences in stroke. After that, as everybody knows, we got an undergraduate program here at UAB, or in the School of Public Health. And as it was kicking off and I was meeting with Melissa Galvin and with Max Michael, I said, you know, I taught undergrads at Emory. We had a Howard Hughes training grant. We all had to teach undergrads and I had to do it for 3 semesters. I said to him, do you know what undergrads are like? They're not mini grad students. They have lives and problems and complications and they don't know where they're going as much. It's just it's a lot different. The classroom has to be more structured. And Max turned to Melissa and he said, should we just hire her in to do something and maybe have an assistant dean? And Melissa said, oh yeah, let's do it. Let's think about it. So that all kind of evolved to the undergraduate program that we know today. And Michelle and I worked very closely. Interestingly, Michelle and I did research together, and she and I were working on Regards research when the undergrad program came to pass. And she was very interested in getting more into the student side. So it was, again, one of those things where you just kind of are moving through life, but you see something and you know you can make a difference. And that was how I felt about the undergrad program. During that same time, I got my first R01, and that's why I always tell people you can do teaching and research at the same time. Started the undergrad program in 2013, and then in 2016, which was, I gotta do math, 8 years after my first postdoc. So keep that again for those of you that are working on putting in grants. It took me 8 years to get my first R01. I mean, these are things that take a lot of time. But got my first R01, and we were looking at the role of the built environment in looking at race and regional differences and mostly stroke. In 2018, I got a Fulbright to go to France in Bordeaux and study the built environment and diet and stroke in France, which was just an incredible opportunity. And I highly recommend people consider Fulbright if you are interested in moving to a foreign country, learning a new culture. It's very different than NIH. It's more about a cultural experience rather than the research piece of it, but it was just a great opportunity to learn some new skills. When I came back, Paul Muntner was getting ready to move away from the Lister Hill Center. So that position was coming open, and I became the director of the Lister Hill Center for Health Policy. In that same time, Paul had just hired on, and because of the undergrad program, I had done a lot of work across campus, working with various schools, and the new provost really wanted somebody from medicine-y side and somebody from arts and science to lead the signature core curriculum committee. Paul called me and said, hey, would you be willing to help co-chair this? And I said, absolutely not. No, I can't do this. I just got back from France, got a new grant. I don't know what I'm doing. He said, please, I'm a brand new dean. I really don't want to say no to the provost. And then it turned out Allison Chapman from English was the other co-chair. I said, okay, we can do this. But again, not something I set out for, but something that really changed my interactions with UAB and being a part of that experience. And then in 2019, George stepped down and he wanted to retire and write more papers, which is now, I see why he said that, because here I stand in 2024 looking for who's going to take over for me so I can go back to writing more papers. The rural study came just after that. We call it the marriage of the Framingham Heart Study with Regards, because it's the best of what Regards does, which is getting out to the people, with the best of what Framingham does, which is really in-depth phenotyping. And that's what we're here to talk about today. That's my long and winding, honest path about how I got to where I am today, which is Regards 3.0, or for those of you in the room, we are trying to come up with the acronym. The second visit for Regards was called SURF. So we're trying to figure out what we're going to call the third visit, and the three that we're talking about are TURF for surf and turf, Smurf, and Vector. So we'll have a vote at some point and figure out what we're going to call it. The 5 multiple PIs are in the bottom. You guys know Ginny and George. Mary Cushman has the glasses and the blonde hair, and then Jen Manley's in the middle at Columbia and is our neuropsychologist with the study. Overall, with regards, I'll kind of breeze through this because you know many of these pieces and parts, and I want to focus more on where we're going in the future. The goal is to get a comprehensive assessment of demographics, major cardiovascular risk factors, things like hypertension, diabetes, lifestyle choices, including diet, my most important exposure, general health, and then also some psychosocial measures. Those were the things we could do over the telephone. You've seen the regards map. The goal was to be across the lower 48 with an equal distribution of Black and white Americans, men and women, and those residing in the Southeast, which does not include Florida and the rest of the country, because the Southeast experiences more strokes than other parts of the country. We really needed a novel study design in order to achieve this. Most cohort studies have a location at an academic medical center. People come into the academic medical center, and that's how they recruit into the study. In regards, we really wanted people to be able to live wherever they were. So we worked with a company, which is why I'm gonna have to leave a little bit early today. I've got to go visit our new vendor who is doing these in-home visits, very much so surprisedly, but they go into homes for insurance visits and to make sure that you're healthy enough to have life insurance. They take your blood, they do your blood pressure. Sometimes they do an ECG, although they're moving away from that. And they can get urine. They can look at other types of heart rate measures to see how you're doing, so the insurance company knows if you're a logical person to insure. We used EMSI both in 2003 and then again in 2013. That company went under during the pandemic, so we've got a brand new vendor called Exam One that we're working with. Since the regard started, we were one of the first studies that worked with one of these vendors. Now, Exam One is actually working with 7 different cohort studies. So today I'm heading to Chicago to meet with all of those 7 cohort studies to talk to Exam One about things they're doing really well in medical research and things they need to improve upon. In the in-home visit, we get written informed consent, which is really important for research, obviously. The physical measures that you can't get over the telephone, the height and the weight, waist circumference, blood pressure. We get an ECG, we collect blood and urine, and then we record all of their current medications. This kind of shows you the overall process. The examiner's in the home, sitting at the kitchen table with the participant one day. The blood then gets flown overnight to our lab. That's our lab in Vermont up in the upper right-hand corner. And this is what it looks like. This is a day in the life of Vermont. This is how many kits they get in one day. It's what 100 participant boxes look like. And, we're not a big Quest. We're not a big company that processes thousands and thousands of blood. This is our group up in Vermont. We've got about 6 people up there to process all of these kits. So we can only do about 100 visits a day. This is what the kit looks like when it goes to Vermont. You can see there are the different types of blood, urine, and then the serum and plasma that have been spun off. The orange tubes that are to the left, those are actually serum and plasma. That's not urine. The urine is the yellow tube all the way to the right. And then we have one whole blood tube so that we can look at, hemoglobin and other factors they're in blood cells. After the samples are processed and stored, we have these giant freezers at UVM. We actually have a whole barn full of freezers. Regards has samples from baseline, from second visit. And so we have this giant barn, and we're about probably half of the barn of these freezers of just stored samples. The baseline repository, this gives you an example of the numbers. There are over 400,000 aliquots that are in the barn. You can see the gigantic freezer yard where all of these things are stored. I always think it's so impressive what they do there. I mean, it blows my mind that they can keep up with all of these individual samples and know how to find them for future studies and keep them safe and available for use. After we recruited somebody in, we do longitudinal follow-up. We do that over the telephone. We call people every 6 months. Our real goal is to ascertain stroke. We want to know if they had a stroke so we can pursue their medical records. But ancillary studies have come online to look at heart disease that Emily Leviton's the PI of. We've got kidney disease. We've done sepsis, fracture. I'm trying to think what other outcomes. I'm missing a big one. But we can go and pick up the medical records and see, what happened. Oh, COVID. We went and looked at COVID medical records. For stroke, we have neurologists look at the record to see whether or not the person had a stroke. Neurologists are really finicky about the definition of stroke, so they want to verify that the person really, truly did have a stroke, preferably with imaging. That's one of the big changes when you talk about how things change and evolve. When we started the study, stroke was mainly asymptomatic. They looked at 24 hours, focal neurologic deficits. That's what defined stroke. But starting in about the early 2000s, people really wanted imaging. Because you could actually have strokes where the symptoms lasted less than 24 hours, but clearly there had been ischemia in the brain. So we also collect imaging wherever we can so that we can get either a clinical definition of stroke or that classic World Health Organization 24-hour focal neurologic deficit. We also started looking at change in cognitive function. Again, rolling with the punches. 1 year into the study, the NIH called us and said, hey, you guys are calling people every 6 months. We would like you to look at change in cognitive function over the telephone. No one had done that before. We had no idea what to do, but we said, okay, no problem. We'll take a look at it. And I'm truly grateful the NIH did that because when that happened, George said, okay, well, we can't afford to do dietary analyses anymore. If we have to do cognitive, we can't do dietary. So 4 years later, the dietary was just sitting there waiting for me because they hadn't been able to analyze it so that they could do cognitive. Our cognitive assessment includes wordless learning, wordless recall, and then 2 measures of memory, animal fluency and letter F. And animal fluency and letter F, people just name as many animals as they can name. With letter F, as many letter F words as they can name. The wordless learning, we read a list of words. Terry can tell you all about this, how much fun this is for our survey research unit. And then the participant has to recall the words. Well, then we wait about 2 minutes and ask them some different questions. And then we say, hey, remember those 10 words we asked you 2-3 minutes ago? Could you tell me those words again? Participants just love it, don't they, Terry? It's really painful. Participants get frustrated. You know, nobody likes to not remember things. But we're very grateful because the SRU has been doing this for 20 years and we have hundreds of thousands of data points. You can see here we've scored over 100,000 animal naming and also letter F now at this point in time. When we call participants every 6 months, about 80% of the cohort will pick up the telephone and talk to us. When we call back 6 months later, another 80% picks up, which gives us usually a 90% on average over the whole year that we talk to everybody about 90% of the cohort about once a year. We have more than 40,000 medical records for stroke alone. We have many more if we include MI, and have over 2,400 strokes, which is really one of the largest numbers of stroke for any study that does this type of longitudinal cohort epi. With the cognitive outcomes, they're a little tricky to know exactly how to use them because we're not doing an assessment of dementia. And right now, people really want to know about dementia. What we have is cognitive function. We know how many words they can recall. We know how many animals they can name and how many letter F words they can do. In addition, we do a really brief 6-item screener every year. So what we've done is create some factor scores. We standardize these variables and create a Z-score, and we can look at memory, we can look at language, we can look at executive function or overall cognition. So when people want to use the data, if you all want to use the data, we have many ways you can consider looking at whether or not people are becoming impaired. We also have a definition of cognitive impairment that is based on a robust normative sample so that, Regards has one of the largest collections of this type of data. We can look at where would people, if they didn't have any other impairments, no strokes, no history of cognitive decline, where should they be? And then we can see whether or not people are declining from where we expect them to be. In terms of retention, this is where the cohort stands currently. We're following 8,000 people currently from the original 30,000 people we recruited. We've had over 13,000 people die in the 20 years that we've been following them, and about 8,000 people withdraw, which gives us an annual retention rate of about 98%, which is really, really high for cohort studies. What's driven this retention success, and this is one of those things I can't help but tell students while you're sitting here, you really have to respect the participant and their time. When you're doing research, it's really easy to get into your research question and want to ask it in the perfect way, exactly with this big long instrument, or maybe something that's frustrating like making them name 10 words 3 minutes later. But that can frustrate participants. And if you're going to have a lot of time or procedural burden for the participants, you want to make sure that they're adequately compensated. What's an example of a procedural burden that may not take that much time? Well, I can tell you, anybody want to guess what the number one thing participants hate to do? Keep in mind, you can collect urine, you can draw blood, you can ask questionnaires, you can collect feces, you can do spinal taps. I mean, think about all the things you can do. What do you think is the thing that really participants are going to say no to and get frustrated? Anyone have any guesses from the research you have done? It's a 24-hour urine collection. I know that sounds so simple because time-wise, it's not that much time. It's just urinating in a jug every time you go to the bathroom rather than in your toilet. But you have to take that jug, put the lid on it, and put it in your refrigerator. People really, really do not like doing it. It's very sanitary. The process we have for them is very sanitary, but it's disgusting. They would much rather collect feces, which is a one-time, they're done, put it in the envelope and it's gone, than collect their urine. It's just, it'll drive them crazy. So that's an example of a heavy procedural burden that you probably need to compensate pretty aggressively for if you want to have a high retention rate. Other things, the other second most frustrating thing for them is food frequency questionnaire. They hate doing dietary recalls. It takes about 45 minutes to do it, and it just, participants find it frustrating. They feel judged because they have to talk about what they've eaten. They don't know what they eat. So that's the second biggest thing that people get really frustrated by. Believe it or not, they're willing to do ECGs. You know, we go into their home, they have to take their shirt off for a stranger. That doesn't bother them, but dietary recalls and 24-hour urines are not things that they enjoy. So we try really hard to always have a customer service mindset. David Rhodes implemented this about 10 years ago after coming from the hospital. We put everybody through Disney training. I think the SRU does something very similar where you always assume that whatever they're saying to you is true and accurate and what they need in that given moment. That frustrates researchers a lot because if a participant says to us, nope, I don't want you to come into my home, we just say, okay, no problem, then we won't come into your home. We don't try to get at the why. We might ask a question here and there, but we just say, whatever you need, let us know when we can come back in. This helps us to retain people and want to be in the study. The reality is life happens. And when you're seeing 20,000 people, lots of different types of life happens to them. So if you can always keep yourself focused on your customer, which is your participant, it helps you with retention, which really drives your study success in the long term. We also do regular mailings, ask them if their address is updated, if anything's changed. We send a newsletter to let them know what the study has found, and also send holiday and birthday cards just to, show them that we're paying attention. In terms of progress, the studies had 133 currently active ancillary studies. So we are always managing lots of different types of things in regards and have had 804 publications since the study started. But what are we doing next? So that's what we've done. Well, we started thinking about what do we want to do with the regards renewal? How can we sell to study section? It's important to keep this study going. And one of the data points that we had is that for the first time in US history, mortality has really leveled off. We had really steep decreases in mortality, particularly for stroke over the last 40 years. But starting in 2013, all of a sudden it flattened out and then started going up even before COVID. So stroke mortality starts increasing again. The life expectancy in the US flattened. We no longer see increases in US life expectancy, as you may have heard from other seminars that have been in here lately. So what we decided we wanted to do was add a new cohort to regards. And I'm going to show you a couple of different slides to show you all the ways we're starting to think about this. In this new cohort, we want to take everybody that we had in cohort 1 at baseline that was age 45 to 64. And we want to recruit a new group of people right now that are age 45 to 64. So it's essentially comparing Generation X with the baby boomers and look at the risk factors that they have in midlife and see how risk factors in Gen X are a little bit different than risk factors in baby boomers. Then to see if that's what's going on to explain some of these differences in stroke and dementia. There are a lot of things that have happened in those time periods. Exposures occurred at different time periods. So the baby boomers, they really had the obesity pandemic hit them in their midlife, in the 40s, 50s, 60s. where Gen X, they started experiencing obesity in the 20s, 30s, and 40s. So we're really interested in if some of these trajectories to obesity, to the rural outmigration, another thing that happened to Gen X, baby boomers were able to live in rural communities. Gen X had to migrate to find jobs. So a lot of Gen Xers left rural communities and moved into urban communities. And then COVID hit them at very different time points in their life. So we're just curious to see what those differences are and how we might be able to quantify them in regards. And here's where it gets kind of fun. We're trying to figure out how to explain this to people. It is very confusing because we have regards 2003 to 2007, which is 30,000 people. About 15,000 of them came in for that second assessment called SURF that I was telling you about. Now we've got about 8,000 that will come in for a third assessment right now. And we're also adding in cohort 2, which is 12,000 people that are 45 to 64, that will create this overall cohort of 20,000 people. So it's really confusing because cohort 1 is not being assessed, their data we've already collected on, to compare to cohort 2, but there's a portion of cohort 1 that's still with us in the third assessment. So this is one slide that we've used to kind of characterize what we're doing. Here's another slide that we've used to try to conceptualize what we're doing. This is more the epidemiology slide, where regards will have 42,000 people. Their visit 1 dates will be between either 2003 and 2007 or 2025 and 2028. And then we follow them longitudinally. So there's different entry points to the cohort. We've also got the SURF cohort. They have a visit 1 and a visit 2 date in that top group. And now we've got maybe TURF, maybe Vector, maybe SMURF, I don't know what it will be called, that will have a third visit. And hopefully this 12,000 will have second and third visits as well. But from that original 42,000, we can pull off a secular trends analysis subpopulation that has 2 groups of 12,000 to compare the 45 to 64-year-olds across 2 different time points. We have a case cohort that many of you that are in Ryan Irvin's class have learned about, where we can do additional biomarker work, genetic work, to understand some of the more expensive risk factors that we can't afford to do in the whole cohort. Those of you that had class with Dr. Leanne Long, you probably learned about Biometeor, where we have another cohort of 4,400 people to better understand biomarkers of hypertension and diabetes. And then anybody in the dementia world, I know Rachel knows this particular cohort, it's our brain health study, where we've actually gone into people's homes. We did a 2-hour neuropsych assessment, and we can diagnose dementia in these people. So there's that complication when you're looking at the data. These are just a few of the studies that are based on actual regards aims, parent study aims, but we have also ancillary studies that are looking at radon, BNP, AFib, trace elements, some imaging data, genetic and other sub-studies, and those are all separate subpopulations that we haven't quite figured out how to include. Lastly, this is another way that one of the investigators conceptualized what we were doing. At the top, you've got regards A, and there are all these different piles. People in the orange are folks that have continued on with us in different way, shape, or form. In the green are those who have died, and in the yellow are those that have withdrawn from the cohort. Then there's regards B. You can see they were not yet recruited in 2000, 2010, and here they are showing up in orange in 2020 to give us the full regards etiologic cohort that has B plus A and then the different piles from A. So now this is where I'm going to ask you guys, when you see these 3 slides that I've kind of gone over a little bit in detail, which one of them is the easiest to digest for you? Who thinks number 1? Okay. Number 2? All right. Number 3. See, this is what happens every time. I think what we're going to have to do is have all 3 in our description document. I think the way that people visualize, hopefully what my goal in the talk is showing all 3, you guys all understand what we're doing, so you can ask me some questions about it. But it's really hard to give people a snap visualization of the various parts of the cohort and what can be done. But I do appreciate you guys going through that exercise with me. What happens when you start a new cohort? Well, one of the most painful things is deciding what you're going to ask. Everybody has a pet domain. These are the domains we're considering for our questionnaire right now. We're in what we call the boxing phase of the cohort. The investigators, we come into the ring, we bring our favorite questionnaires. You have to justify, if it's your questionnaire, you have to have all the reasons why this is the best questionnaire. And if we don't ask it, we're going to be making a major scientific mistake. And then we vote. Basically, as a group of questionnaire committee, we vote on which one of these domains gets to stick, because we are very focused on participant burden. And we do not want the participants to have to fill out more than an hour and a half worth of questionnaires. So we try to get it down to an hour and a half. And I have to tell you, this is the most painful part of it. We kind of walk away sometimes and don't speak to each other for a week or two because the investigators can be pretty mad if their domain is cut. But it is a fun process. And it's one of the stages that we're currently at in this grant. We do have a second aim in the cohort. For those of you that are really interested in following the literature right now in dementia, there are a group of investigators that think that we should be defining dementia based on blood rather than cognition. It would be equivalent to what cholesterol did for heart disease. Previously, heart disease was defined by chest pain, actually having a heart event. As we learned more and more about cholesterol, we started saying, wait a minute, if we have high LDL and we lower the LDL, we can lower the heart disease risk. They're trying to do something very similar with dementia. So they're measuring amyloid, A beta 4042, and tau in the blood. And there's a whole group, and it's a big group, probably 70% of the clinicians want to define people as having dementia. If their amyloid, their A beta 4042 goes up or their tau goes up, then the person will be defined as having dementia, even if they have no cognitive impairment whatsoever. And there are two big medications that have come out that are really hard on the kidneys, that are really expensive, but they do lower tau and A beta 4042 in the blood. So I know probably a lot of you are not in the dementia world, but this is hot stuff in the dementia space. Like we're really arguing about it as researchers right now. Should we be defining it by blood and telling people that are perfectly cognitively intact that they are on the path to dementia when we don't actually know if these biomarkers put them on the path? But Regards is in a unique position that we can measure these biomarkers at baseline, second visit, third visit, and now in this new cohort to give people a better idea of what are the normal levels of these biomarkers and how do they change over time. So that's one of the things we'll be doing, using these emerging ADRD blood biomarkers to better understand what's the prevalence of disease with these biomarkers and how many people are using these new ADRD medications. Rachel probably could give you a better idea in Birmingham of what's happening, but in a lot of ADRCs, which are Alzheimer's disease research centers across the country, there's a 6 to 12 month waiting list to see a neurologist because people really want to get on these medications. The pharmaceutical industry is putting them on TV. They're talking about how these medications may slow the onset of dementia, and people are trying to get into clinics so that they can be worked up for dementia to see if they qualify for these medications. So it's really, really timely, this particular study. We have measured some of these in Regards at baseline because just like there are 60 or 70% that are ready to run with these biomarkers, there's another 30 or 40% that says we don't know what these biomarkers are, if they're even associated with dementia. So we looked in some of those random cohorts that we have, and we looked at GFAP, neurofilament light, and UCHL1. We also looked at total tau, but it's not the best form of tau. These biomarkers are a mixed bag. So tau and amyloid are actually related to the plaques that you find in the brain with Alzheimer's. These other markers are more indicative of structural changes to the brain. So they get it maybe a stroke or other types of structural changes, but also can be associated with dementia. For these analyses, we do have the 4-test battery that I mentioned, the wordless learning, the delayed recall, the letter F and animal naming. And we were able to take a look at the biomarkers and see that, okay, we don't know what they are. We're not totally sure, but we do see that those with the highest level in the green up here do experience more cognitive impairment than the people that are in the tertile 2 and tertile 1. So that helped us with selling the grant that, you know, maybe we don't know what the biomarkers are, but we do notice that they are defining people who go on to get disease. Interestingly, also, they are associated with loss to follow-up, which this has triggered a whole new exploration of science in Regards. because our concern is if the people that are in the green, which have the highest level of these biomarkers, are also the most likely to drop out, it's quite possible that one of the reasons someone drops out of regards is because they develop cognitive impairment or dementia. And so we have to figure out, what do we do about that? Not a reason to panic. Again, staying on the path and reinventing ourselves. We're going to work with some mathematical modeling methods to see if we can leverage some newer techniques to actually use these people in the definition of dementia. The biomarkers are also associated with mortality. So that was something that we were kind of surprised by, not just dementia mortality, but all-cause mortality. So these indicators of changes to the brain are strongly associated with risk of death. Lastly, and I know we're mostly epidemiologists in this room, but for the social scientists as well, we decided we wanted to put an engagement aim in the grant as well. So this is so that we can engage researchers and participants to have more collaboratory research. We're forming a participant advisory board and getting great guidance from some collaborators we have at Weill Cornell. We did a pre-PAB launch focus group, and 2 former epidemiology students led it, Demetria Hubbard and Marquita Brooks. And what we found with these semi-structured interviews, we created themes and got a thematic analysis to understand what the participants want from about, I'm trying to remember, now this is one where it does matter. I think we had about 25 people in the final cohorts. This is what the participants told us, that it's important that the PAB is formed and it functions with a core set of principles. So they don't want us changing back and forth. They want a core set of principles that underlie their feedback. And again, PAB is Participant Advisory Board. They want to be able to help us inform and disseminate research, like newsletters, what's on our website, what we send out to researchers. They would like to have some say there. They want a formal process to form and maintain the PAB, so it's known who's on it, how they rotate in, how they rotate out. And they want to have certain values. They didn't tell us what those values are, but they do want it to be a value-driven group, so that everything we do is driven by the values that the PAB comes up with themselves and then focuses on those activities. So that's it in a nutshell. Those are the main things that we're doing in regards. We're actively taking ancillary studies, as always, for people that are interested in the second in-home visit. It can add exposure data. It can add outcome data. You can refine the outcome data. If you don't like the way we define stroke and you've got a better way to do it, you can come up with an ancillary study to change the definition of stroke. You can develop additional statistical methods and epidemiologic methods to better analyze, like what I mentioned with dementia. We're really looking for a method that can help us to incorporate informative censoring or dropout, and how does that relate to dementia and cognitive impairment. It can be in all of regards, or it can be in just a sub-study. How do you get involved? This is our website. I also put the rural study website on there, even though I didn't talk about rural, because folks are always interested. You can easily submit proposals that we can review if you're interested in doing any of these things, but you can also just email me. Sometimes it's easier just to come to my office and kick the tires on an idea if you've got something you're thinking you might want to do before you start spending too much time writing about it.